So very good evening to all of you. This is our 17th online class, and this is the last online class on the head neck malignancy. As we know that our theoretical knowledge is all in vain if we are not implicating this knowledge into our practical approach. So basically, this is an practical classes, how to proceed for a case, how to diagnose, what treatment modality you have to choose. And for this, we have Dr. Neha Lal. She is a senior resident, HBCH, MP, MMC, C, Varanasi. And the best part is that Dr. Punita Lal ma'am is here with us to guide us. And Dr. Rashi is also here. So Dr. Neha, you can start now.
Very good evening, everyone. Today, I'll be discussing two cases. And along with the case discussion, I will also be throwing some light on the pertinent point and how we should diagnose a case and how effectively the clinical symptoms, the investigation lead to the treatment management of the patient. So my first case is of 57-year-old female. She had a history of sore throat for last 1 month, and she also gave of 5 kg weight loss in last few months, and she had complained of pain on swallowing. She's described a lump on the left side of her neck. On examination, it reveals a 3 centimeter left translunar mass extending to the posterior oropharynx and multiple bilateral 1 to 2 centimeter lymph node at level 1, at level 2. And the CT was confirmatory, and the FNSC of the cervical lymph node reports squamous cell carcinoma, and remaining workup including PET and DL was negative for other site of disease. So other symptoms that we can get in oropharyngeal carcinoma are painless neck mass, deep-seated otalgia, trismus whenever there is involvement of pterygoid muscles, odynophasia and dysphagia, which is painful and difficulty in swallowing. This over here, I just want to stress upon, if the patient complains of otalgia, so it can either be due to involvement of the cranial 9 or trigeminal nerve. So the posterior 1/3 of the tongue involvement, tonsillar fossas, inferior nasopharynx, parapharyngeal and retropharyngeal spaces, they have a supply of glossopharyngeal nerve, which as we know, the ear is supplied by the tympanic nerve of Jacobson and the tympanic plexus. It forms a ganglion, which is supplied to the cortex. So whenever there is an involvement of these nerves, so the patient will complain of otalgia as a referred pain. And similarly, the V3 cranial mandibular nerve is involved with the involvement of anterior 2/3 of the tongue, palate, inferior oral cavity, lower teeth, mandible, and major salivary gland involvement. So we have to look further to understand the cause of the otalgia in such cases. Coming to investigation, first of all, the patient underwent the routine blood investigation, basic blood chemistry, viral markers, and testing for HPV in the biopsy specimen. P16 IHC testing is done, and CT thorax is indicated in all patients which have N2 or greater nodal disease, advanced T stage, and it will help in diagnosis the lung mets. And when we are ordering a CT thorax, we have to distinguish whether it's a lung mets or whether it's a lung primary. So to rule out that, the lung mets are well circumscribed and these are peripherally located nodules, whereas the lung primary usually have the spiculated irregular mass with hilar and mediastinal lymphadenopathy. The oropharynx cancer, in which the can be further divided, the staging can be divided on the basis of HPV P16 positive cases and negative cases. And in cases where it's not been tested, we'll again go with this test, this oropharynx P16 minus staging. The T1, T2, T3 is on the basis of the size, which is less than 2 centimeter, 2 to 4 centimeter, and more than 4 centimeter. Whereas the T4A and B are divided further into moderately advanced and very advanced local disease. T4A is where the tumor invades the larynx, extrinsic muscle of the tongue, medial pterygoid, hard palate, or mandible, and wherein in the very advanced local disease, tumor invades the lateral pterygoid muscle, pterygoid plates, lateral nasopharynx or skull base, or in cases, carotid artery. In the N staging, the N1 is the where in the single ipsilateral lymph node, 3 centimeter or smaller in dimension. N2 is lymph node larger than 3 centimeter, but not larger than 6 centimeter. And N2 is divided into A, B, and C, wherein the N2A is single ipsilateral lymph node larger than 3, but not larger than 6 centimeter. N2B is multiple ipsilateral lymph node, and N2C is metastasis in bilateral or contralateral lymph node. N3 is lymph node larger than 6 centimeter in greatest dimension. N3E is a lymph node larger than 6 centimeter in greatest dimension without ENE, and N3B is ENE positive. So the difference that in the staging of in a HPV 16 positive is the T4 is not divided into A and B, and the lymph nodal staging is simply N1, N2, and N3, where in just the lymph size is less than 6 centimeter in N1 and N2, and multiple lymph node, and N3 is more than 6 centimeter. So in our case, the staging of the tumor was the T2, N2, and M0. The diagnosis of carcinoma left tonsil T2, N2, M0, stage 4A was made. The routes of spread is important to discuss and know. So on the basis of spread, we are we'll get to know what all structures to include in our while we are treating the patient in the radiotherapy. So first of all, the spread in oropharyngeal carcinoma is of direct extension, lymphatic spread, which is very common, and hematogenous metastasis is less common. Another important point is submucosal extension, which are shown, which is a raised erythematous region without distinct orders or ulcerations. These are best appreciated by direct visualization. So for those who are attending, students, I would like to ask the question, what is the most appropriate therapeutic strategy and in the patient that I have just mentioned, whether the first is the concurrent RT and full dose of cisplatin, induction therapy with TPF, followed by radiation, and low dose concomitant therapy, concurrent RT and cetuximab, and or any of the above. So you can just put your answers in the chat box.
Neha, would you want to discuss a bit before, or you have more questions? We can do either ways.
Ma'am, I'll be discussing most of the options that I've given over here. I'll be discussing in my later slides.
Yeah, but like I thought, I mean, that's the final treatment, whether what you are going to do. But like investigation that you mentioned, you talked about CT thorax, you talked about PET, you talked about DL scopy. So those are important things that sitting in the ground reality when you sit in a outpatient, how important is DL scopy? Why is it done? And what added information it gives? Is PET CT essential? And you talked about CT thorax, that was rightfully pointed out when you will get CT thorax done. So that's one thing. Sorry, I may have missed out. I also wanted to ask you, was the patient a smoker?
No, ma'am, the patient didn't give any history of addiction.
Okay. Okay.
So in this patient, we had workup PET and DL was done for which was negative for other sites of disease. So it was non-metastatic disease, and the patient did not have any other.
So tell me, I mean, you did a PET, and of course, DL is a complementary investigation, and then you did a CT thorax. So
In cases which are locally advanced cases, we can go for CT thorax, and DL scopy is important to look for certain, because if there are some mucosal which can be better appreciated by direct visualization or by DL scopy. So if the lesion is small and it cannot, the extension to the larynx and other structure in cases of oropharynx, it is very difficult to do it otherwise. So we need to go for a DL scopy to understand the local extent of the disease. And
the mucosal spread.
Yes, for the mucosal. And for PET, we can rule out whether there is any distant mets or lung mets. Also, we can rule out PET CT if we are doing.
So I just, again, I'll rephrase my question. So DL scopy, you say, is a must because one, it gives you mucosal spread, and two, it gives you a biopsy if required. Now, the thing is that when you are getting a CT thorax done, when you're getting a PET CT done, then do you really need to get a CT thorax done over and above a PET CT?
No, not over, because the PET, we usually, along with the PET, we use the PET CT along with it, or PET CT. So there will be a CT scan along with it. So we will not need another CT thorax.
Yeah, because that will be an overkill. I mean, either we get a CT of the face and neck, and if required, of thorax, otherwise just a PET CT.
This one.
Neha, have you done this FNAC from the cervical lymph node for confirmation? Apart from the biopsy from the primary site?
FNAC from the cervical lymph node was done for and the biopsy from the lesion was taken. Both came out to be confirmatory of squamous cell carcinoma.
That's right. Somebody has said rightfully that it will tell you, the DL scopy will help you with the local extent. And that is what Salman we mentioned, that the exact mucosal spread, the distal most extension is best recognized or identified by DL scopy, which is what Neha has said. And of course, it will also give you biopsy. And vocal cord mobility. That's another thing. Right. Please go ahead. Surbhi?
Yeah, ma'am.
Rashi, anything to add further?
No, ma'am, that's okay. Basically, DL scopy and guide biopsy, FNAC from the cervical lymph node, and CT thorax. I think these are the mandatory investigation which to be done. And PET scan if the patient is having the N2C disease. I think in this case, PET scan can be advised if you are having this facility in your institution.
Right.
Can we proceed further?
Yes, Neha. The most appropriate treatment in this patient would be, I'll just go through some of the evidences. So non-surgical treatment option for squamous cell cancer, as we see, there was many phase 3 trials which was done. So I've mentioned few of them. Along with the RT, concurrent chemotherapy and RT with cetuximab, TPF followed by radiotherapy, TPF followed by RT plus carboplatin, and it was shown the absolute benefit was whenever in the 5-year and overall survival was more with RT with concurrent chemotherapy and RT with cetuximab. So the meta-analysis of chemotherapy in head and neck McKenzie trial, the famous one, which came almost a decade back, it included 63 randomized trial, and there was a total number of 10,000 and above patients. The median follow-up was 6 years, and it was found that the absolute benefit of at 5 years, the concomitant chemotherapy gave an absolute benefit of 8%. Whereas the adjuvant and the induction chemotherapy gave benefit of 1% and 2% only. And with an update of McKenzie, we also got to know that the age matters in cases of head and neck cancer. So patient younger than 50 years of age, there is an 24% increase in survival, whereas older than 70 years of age, there's only 3% increase in survival. With this, the above evidence, we can know that if we are thinking about giving the radiotherapy, it has to be a concurrent chemoradiotherapy and not the adjuvant or the induction in this case. The next question comes, what is the most appropriate irradiation technique in this patient, whether it will be a classical sequential IMRT, whether in SIB IMRT, SIB VMAT, or any of the above, or we can say also 2D conventional radiotherapy. You can put your answer in the chat box. Before going in detail, the conventional radiotherapy field border that was used was the two parallel opposed lateral field border and a low anterior neck field. The lateral fields included the primary tumor at the upper neck, and low anterior neck field or the supraclavicular was used for treating the lower neck. The lateral field borders were superior was the cranial base. The inferior was whole neck by pulling the shoulder as far as down possible. The posterior covered the spinous processes and anterior 2 to 3 centimeter margin to the tumor. Whereas for the superior was whole border of the thyroid notch, and it was matched with the lateral field inferior border. The inferior was the border of the land field was the inferior edge of clavicular head and lateral 2/3 of the clavicle.
Neha, can we just for our understanding, before we go on to the standard of care IMRT, we talked about the superior border, because everything starts with conventional radiotherapy. If we understand that, we'll understand IMRT also. So why did we need to go up to cranial base? Anybody can answer that. And why do you need to pull the shoulders down? That is, I think, an important thing from a radiation oncologist perspective at the time of planning. And what all do you cover when you are taking your posterior edge of the field behind the spinous process of vertebrae, right? And then anteriorly, of course, you flash in air, which is about 2 to 3 centimeters anterior to the tumor, like you rightfully pointed out. That's right. So you want to cover the retropharyngeal group of lymph nodes, and so that's why you go up to the base of skull. Shoulder push down to prevent the shoulder coming into the beam. What will happen if the shoulder will come into the beam?
Anyone can answer.
Okay, attenuation. Somebody said attenuation will happen, and so the dose that will reach up to the midline will be less. So the dose received by the neck node levels at that area would be less. And yes, somebody's also mentioned about dose uncertainty, because there'll be dose perturbation or attenuation. So, and then you've placed a lower anterior neck, rightfully so. Yeah, we can probably move. So we need to know about the conventional field so that we know what areas to cover in case of a tonsillar primary with neck nodes as has been described by Neha. So now, if keeping this as our baseline, and then we move on to the IMRT fields, we'll probably be able to understand better. So when you are giving a 3-field plan, to what all levels are you covering in this then? apart from the primary, it's microscopic extensions, which you would have covered by covering the tonsillar region the way it has been described. And then you have covered what level nodes?
We'll cover the from level 1 to 4 lymph nodes and also the retropharyngeal group of lymph nodes in this.
Yeah, so your aim is to cover all the level, yes, 1 to 5 lymph nodes, because the level 2 is positive, is involved. So we will be covering the level 5 also in this case, right? And you have covered by going behind the styloid process, spinous process of the vertebral. Yeah, you have covered both sides, and you've covered all the levels, relevant levels that need to be covered, including the retropharyngeal. Now, if you take us to your IMRT plans, we'll probably be able to understand better, Neha. Surbi, any further thing that we can ask?
Yeah, what's about in convention planning compensator or other beam accessory device you would want to add, Neha?
Yes, ma'am. For will require the asymmetric jaws and the compensators for the divergent beams. So that is one thing that we have to add for half beam block or asymmetric jaw for treating the bilateral field and the low anterior neck.
Yeah, because the field tension we have to take care for this to avoid the heart is. Okay. Now proceed. Rashi, you want to say something? You want to add something?
No, ma'am. I will add further in IMRT, I think.
Okay. Neha, proceed.
Right.
So from the recent era, wherein all the conventional planning, we have moved to a conformal radiation with the help of IMRT and also the VMAT. The reason behind moving on to this is when this paper was published long back in 2004, the 3-dimensional conformal versus IMRT in head and neck cancer patient, and the dosimetric comparison was made, and it was found that the patients who were treated, they had a better conformity, which is the V95. It increased from 85% to 95% when we shifted from the 3D CRT to IMRT, and also the doses to the parotids were reduced from 59 gray to 41 gray. For spinal cord, the Dmax reduced from 40 gray to about 30 gray. So we had the advantage of IMRT was the better conformity. The doses to the critical OR was reduced, and another thing is whether we can use this SIB IMRT or the conventional the boost concomitant boost RT. So there was a paper by Nancy et al. Which compared the two, in which there was all patient of CA oropharynx, and 41 received SIB IMRT and 71 received the conventional 2D RT with late concomitant boost, and it was given along with the concurrent chemotherapy, cisplatin 3 weekly cycles. Of 2 cycle was given 100 milligrams per meter square, and the median RT dose was 70 gray, and the parity dose constraint for IMRT was mean dose were less than equal to 26 gray, and they found that they had a significant advantage in terms of percutaneous endoscopic gastrostomy dependency and severe xerostomia at 2 years in favor of SIB IMRT. With this evidence and the previous one, we can understand that the IMRT or the use of VMAT and along with the SIB technique, we can have a better the conformity, and also the doses to the critical OR is reduced. So we are and mostly, I think at the most of the centers, are being preferred are the SIB technique if we are using HR and the high risk and the low risk areas. Since so far we have discussed the RT only, and so was there any role of surgery in our case in the patient that of a CA tonsil locally advanced? So I have the 4 options for the students.
Yeah, can I just add, sorry about this, but somebody asked a very pertinent question on your conventional RT slide. If you could go back to that. Somebody asked, how do you place a junction? No, इससे पहले वाली, इससे पहले. नहीं, इसके भी पहले. हाँ, the conventional one, the conventional one.
Yes, so
So, yeah, please explain. And somebody asked, how do you place a junction?
What we do, the lower border of the lateral field, it should be just the superior border should be the lower border of the lateral fields, and that should be around the thyroid notch, and it should match with the lateral border, and the inferior is at the inferior edge of the clavicle, and the lateral is at the 2/3 of the clavicle.
So there is somebody who says that we should give a gap of 1 centimeter, keeping the penumbra. And we have some people, some participants who have raised their hands also. Let me see who's been there. You can write it down, or Survi, can we allow them to speak? Or
better if they can write down the chat box.
Okay.
Yes.
If anyone have any query, please write down on the chat box, please.
That's right. So, feathering can be used for matching. Okay. Somebody has given us one suggestion that we use a gap, and then junction matching, how much gap to give. Do we give a gap here? What is the technique that we follow is the question. See, in today's this thing, most of the linear accelerators now are giving you the asymmetric collimation, and you use single isocentric technique, and you can use you can avoid cold and hot spot. First, let's talk about, let me just ask, why is junction a problem? जंक्शन पे क्या हो रहा है? एक 2 पैरेलल अपोज दे रहे हो आप, और एक सिंगल लोअर लैटरल दे रहे हो. सो इफ यू गिव अ जंक्शन, क्या होगा? Why junction creates problems? Anybody? कोल्ड या हॉट स्पॉट. ठीक है, कोल्ड और हॉट स्पॉट क्यों आते हैं? Overlapping leading to hot, that's okay. But why is there overlapping? Divergent beam, that's right. So the answer lies in divergent beam. So that means, because if you give a divergent beam in a parallel opposed setup and in your lower anterior neck, तो कहीं पे कोल्ड होगा और कहीं पे हॉट होगा, डिपेंडिंग कहाँ पे क्रिसक्रॉस इंटरसेक्ट करता है. बट व्हाट हैपेंस इज दैट इफ वी आर एबल टू टेक केयर ऑफ द डाइवर्जेंट बीम, then divergence of a beam in that particular field, then that will be a straight line. How to ensure a straight line? Can anybody tell? Half beam block. So in olden times, whenever we were giving the lower anterior neck and all, we would put a half beam block. Where do you place the half beam block, Salman? Collimator rotation?
Yes, it can be option.
Yeah. And couch rotation, yes. Half beam block कहाँ लगाते हो? किस part of the beam में? हाँ, somebody said center. बिल्कुल. Center में क्यों लगाते हैं? Center तक half beam block क्यों place करते हैं? to get a straight line, because center पे क्या होता है, अभी we'll come to monoisocentric. Center पे क्या होता है, central axis पे क्या होता है, divergence कितनी होती है? Has no divergence. At the central axis, there is no divergence. So अगर आप वहां पे field को काट लेंगे तो सीधी line जाएगी. It will not overlap into your parallel oppose. Is that clear? You can put a Y if you feel okay. Right. Now, so that was when we did not have multi-leaf collimation and asymmetric jaws. अब हमारे पास asymmetric jaws आता है जिसमें we can close the field from below, go up to the center. So वहां पे आपने एक straight line create करी और आपने parallel oppose को treat किया. उसके बाद you pull the lower jaws down and you close the parallel opposed part of the beam up to the center and take your gantry at 0 degrees and treat the LAN. So again, you are at central axis. So the lower part of parallel opposed and the upper part of LAN, all the edge of the field is formed by the multi-leaf collimation at the central axis. So with single isocenter, you have removed divergence and therefore the junction is there without any divergence. Is that making sense?
I think it is clear to all.
Okay. I think now we can move on. Rashi will tell us about the IMRT.
नहीं मैम, आपसे अच्छा नहीं आता.
अरे नहीं, ऐसा नहीं है भैया.
Ma'am, somebody has asked, can you please repeat? Neha, you can proceed. Otherwise, we will not be able to complete both the cases.
I was talking about any role of surgery in this patient, or would the surgery add morbidity, or it will give a comparable amount of toxicity or morbidity to the patient, along with, or it will not add to any survival, or do we have the role of TORS in advanced cancers of this oropharynx? So the first of all, the TORS and the laser surgery are for earlier disease, and the smaller ones, T1 and T2 lesions. And for the other surgical approaches which we have for the advanced disease are the transoral approaches, visor and the lip split with or without mandibulectomy, and lip split with mandibulectomy. And these approaches, the first one, the transoral, are because of the approach, the surgeon goes through the oral cavity, so it's cosmetic, but it limits the exposure. The lip splitting has the modest cosmetic disadvantage with excellent posterior exposure for mandible, and whereas paramedian or midline mandibulectomy are used for avoidance of damage to the alveolar nerve. So the surgical approaches are because the if the disease is advanced, it will lead to removal of the swallowing structure, the base of tongue, and the other structures, which will lead to very cold. So the preferred is the radiation in this patient. The treatment plan which we had given this patient was concurrent chemoradiotherapy with weekly cisplatin at 40 gram per meter square, and the high risk volume were treated with the 66 gray infraction was treated with 54 grain 30 fraction at 180 centigrade per fraction using the SIB technique. And the target volume which was used is the GTV included the gross macroscopic tumor and lymph node. The CTVH included the GTV with 1 to 1.5 centimeter margin, and we have to go for 66 to 70 gray for CTVHR, and the involved nodal level, entire level was included. And for CTV-LR, the low risk uninvolved neck node, and in this case, it was treated up to 54. So, Another question which comes is the PET-CT fusion and is PET-based
Dr.
fanning.
Neha,
This one.
Dr. Neha, before this, there is one question in chat box. What is your opinion on 3 volumes and 3 weekly chemo?
3 volumes and 3 weekly go.
So what is your opinion about 3 volumes?
We can also use the high risk, and the intermediate risk includes the involved lymph node, 1 ichneum above and the below, and for the low risk, the uninvolved neck nodes, and the patient can also be treated using the 3 volume, the HR, IR, and the LR, and the cisplatin, which is given is concurrently, can be given either 3 weekly regimen or weekly regimen. So if the preferred one at our institute is in most of the patient is the weekly cisplatin regimen, which is being used.
Could I come in?
Yeah, definitely, Ashutosh. Welcome.
Yeah, so regarding 3 weekly and weekly cisplatin, actually studies have shown that 3 weekly cisplatin has better anti-cancer effect rather than weekly cisplatin. However, the toxicities are quite high and the patient compliance may not be that good. So many institutes have opted for 3 weekly cisplatin in divided doses over 1 to 3 days, or into weekly cisplatin, where the patient general condition is a little more compromised. People can even go in for daily cisplatin or twice weekly cisplatin. So various combinations are there. The most commonly used one is the weekly cisplatin. Effectively, the response-wise, 3 weekly cisplatin is thought to be better.
Yeah, Dr. Ashutosh, but in our setup also, we have seen more toxicities with 3 weekly.
I agree.
Yeah,
And
weekly cisplatin at our institution, because patient get more hydration with this weekly regime, na? So one thing, compliance is better with this. Yes.
So one thing is 3 weekly cisplatin has been sometimes associated with unexpected sudden deaths, especially due to cardiac failure, due to either overhydration or the toxicity from the drug itself. Now, this could have affected the acceptability of 3 weekly cisplatin rather than weekly cisplatin.
Yeah, and about 3 volumes, what I say, we prefer in our institute 3 volumes. So it is, I think, your practice. Depends upon your practice. Either of the way you can do it.
Completely agree, Dr. Rashi. Nancy Lee and many others, Gregor and all, they have defined the 3 volumes.
They have.
The RTOG group has, however, slowly evolved into 2 volumes rather than the 3 volumes. So there is no data at hand about the superiority of one over the other. So it's more of a question of practice orientation. But one point to be noted is, if there are multiple nodes, positive nodes at multiple levels, then that area needs to be, that particular area we could perhaps include in a 3rd volume, or maybe leave out the low risk and just give a high risk and an intermediate risk alone. So if there are multiple neck nodes at various stations, then you may not have a low volume, a decent volume of tissue left to define as a low volume disease. So perhaps the whole neck also, it may not be suitable to go up to 66 gray. So the nodal stations themselves could be irradiated to 60 gray, while the nodes with a margin around could be irradiated to 66 gray. Again, that is a matter of controversy, and involved field versus involved node RT, even in head and neck, is being debated.
Yeah, Dr. Ashutosh. In our institute, what we follow 70, 66 and 63 volumes. And one more thing, Dr. Neha, are you discussing about OARs also? Which OR should you draw? Are you discussing about those also?
I am not, because I'm presenting two cases, so I thought it will take up the entire time.
Okay. Yeah, time is less. So we know we should see the dose of the pyruvate also, the OARs that you want to draw. Can you tell the names?
So in head and neck cancer, the commonly drawn OARs.
In this patient, which are important, not tell about the eyes and the retina and these all. In this patient.
So bilateral parotids are the important structure that we need to draw, and the dose is D mean less than 26 gray, and the spinal cord, the
what is your opinion about constrictors? Actually, now we are drawing constrictor also. The point I want to draw your attention for constrictors. DARS, yes, DARS, that is important. Okay, so maybe at your level you can mention DARS are also very important, but not at the level you need to compromise your target volume. And one question in chat box, Dr. Neha, about cetuximab. If there is a head-on trial between cetuximab plus RT versus cisplatin RT.
Neha, I think she has not connection.
Okay. So, Dr. Surbi, are you giving cetuximab? And in our institute now, we are not giving cetuximab at all.
No, we are not giving. The basic reason of us is the financial problem. The second, we are more happy with the cisplatin. I think it's still cisplatin is the standard of care. Concurrent.
Yeah, and there are some trials, and they have mentioned cetuximab is not actually, they have not given any survival benefits. Cisplatin is superior.
We just want to ask from Punita ma'am also about her comment.
Yes, now it has been proven in the de-escalate trial and all that cisplatin is superior, and the toxicity profile changes if you give cetuximab, but it is no less toxic. So both ways it is cisplatin if we have to give. So, cetuximab can be left for very, very select situations.
Neha, I think she has lot connection. Try.
No, Neha is there.
She had rejoined, yeah. Neha, can you hear us?
So sorry, I think some network issue.
Yeah, no problem. You can continue.
So I was telling about the OARs that we can contour. The important ones are the bilateral parotid, spinal cord, and along with that, we can save the laryngeal structure for later. We can reduce the patient having any difficulty in deglutition, and I think that accounts apart from that, we also contour the bilateral cochlea and the optic apparatus. Okay. So the next coming to the next thing, that whether PET-CT based planning is and essentially for correct treatment volume delineation. It was found that if we fuse the PET-CT and the primary GTV-CT and GTV-PET, the overall there is a reduction in the size of the PTV and also in the node. So PET can be used for the planning purpose by using the fusion. The next question for the students is what is the likelihood the patient's tumor is HPV positive in this case? The first option is 25% to 35%, 40 to 50%, 60 to 70%, and fourth is 70 to 80%.
This was non-smoker, na?
Non-smoker patient. The answer is the likelihood in patients, the oropharyngeal patients, the HPV positive patient have risen, and in Paris, I think somewhere it was mentioned that rise in the cases is more than 200% in patients being HPV positive that are being diagnosed now. So the overall is the likelihood is almost 60 to 70% in a non-smoker patient of oropharynx. And the patients, mostly the HPV positives, are the younger ones. The male is to female is 1:1. And whereas in the HPV negative, the patients are usually older. The sites are mostly larynx on the hypopharynx and or oral cavity. And the risk factors are sexual in case of HPV positive, and in HPV negative, tobacco. And the cofactors are the marijuana in case of HPV positive. The other are the factors in the HPV negative are the diet or hygiene. The presentation is unknown. Incidents are increasing, and there are less comorbidity in the HPV positive patient, and the prognosis is better. Whereas in the patient having the less incidence with the of HPV negative, and the comorbidities are usually greater and found in older population also, the prognosis is worse. So the next question comes: what absolute percentage improvement is in the survival is one likely to see in a patient whose primary tumor is HPV positive compared with an HPV negative? The options are 5 to 10%, 10 to 15, 15 to 25, and 25 to 35%. So I'll go to the next slide. The RTO 129. They stratified the patients according to the tumor site, nodal stage, and the ECOG performance status. The tumor site was larynx, non-larynx, nodal stage in N0, N1 or N2AB, N2C, and N3, ECOG 01, and they randomized the patient into standard fractionation with 70 gray 35 fraction and cisplatin 100 milligram per meter square on day 1, 22 and 43, and in arm B, accelerated fractionation with concomitant boost of 72 gray in 42 fraction along with the cisplatin was given. And it was found that the patient was also, like I just said, was stratified along to the tumor characteristic, and the it was found more the HPV positive in more in the white race, and those who had cigarette smoking pack years less than 20. And the 2-year outcome, which was the overall survival at 2 years, in the HPV positive patient was 87.9%, whereas in the HPV negative was 65.8%. And the progression-free survival 71.8% in HPV positive and 50.4% in HPV negative. So the HPV positive patient have better overall survival and progression-free survival. But I think there isn't any evidence to use lower doses in case of HPV positive. But I think there are studies which are undergoing. So I'll be coming to the next case.
Before starting this case, can you just summarize the thing about this patient? What will be your dose prescription if you are planning the conventional setting?
In the conventional setting, if we are using the doses using the parallel field and the LAN, then we can give the doses, the parallel opposed field to 44 gray, the lower neck field we can go even up to 50 gray, and for the phase 2 we can go up to 70 gray by when wherein the spinal cord the posterior border needs to be shifted ahead so that the dose tolerance to the spinal cord is well within the normal limits. And if we are using the IMRT or SIB technique, then we can go for the high risk volume up to 66 gray and the low risk by to 54 gray. And we can also go with the conventional fractionation of 70 gray and 35 fraction. And and also, like you just said, the HR, IR, and LR volumes can also be treated according to the institute protocol.
Okay, any question from participant? Okay, now second case.
So the second case is of 45 years old male, farmer by occupation. It presented with an ulcer over right upper alveolus for last 4 months, pain and swelling over right cheek for last 1 month. And on examination, it was found that an ulceroproliferative growth was present in the right upper alveolus from lateral incisor up to the molar tooth. And in the neck, right level, 2 lymph node was palpable, which was around 1 to 1 centimeter. The patient had undergone the laboratory test and the radiological studies, CT and MRI both. CT, which I'll mention the findings of the CT and MRI in the next. The CT thorax, it was there was no evidence of lung mets. The patient also undergone and fiber optic endoscopic examination with biopsy, which confirmed this squamous cell carcinoma. Dental evaluation was done, baseline ophthalmological examination, and speech and swallowing was done. So the patient, the mass was in the right maxillary sinus of around 3.7 into 3.4 into 4.2 centimeter. It causes the erosion of all 4 walls of the maxillary sinus with extension beyond the sinus walls. Superiorly, erosion of the floor of the orbit with subtle intraorbital extension, medially the nasal cavity with inferior turbinate involvement, and inferiorly erosion of the alveolar process and gingivobuccal circles. The MRI confirmed the finding were similar with the CT. The size of the disease confirmed was 4.7 to 4.1 to 3.5 centimeter, and it also also shows there was an erosion of the inferior wall of the right orbit with minimal extraconal and intraorbital extension, mild extension in the right nasal cavity, erosion of the pterygoid processes, medial, and there was no evidence of any perineural spread of pterygopalatine foramen or foramen rotundum. So for evaluation of a maxillary sinus patient, we require the MRI and the CT both in this patient, as the MRI in the T1 weighted gadolinium contrast used as a supplement for CT, wherein the T2 weighted distinguished the tumor, which is adds a low signal from the obstructed secretion, because the sinus usually have some secretion and that may be confused with the disease. So the T2 weighted images are important to distinguish. The tumors spread into the surrounding soft tissue areas, especially the cranial fossa, and the intracranial or the perineural or the leptomeningeal spread can also be very well seen with the MRI. And for CT, for any cortical bone lesion or extension through the cribriform plate or orbital walls, and it is also important for local invasion into the surrounding bony structure. Coming to the staging of the maxillary sinus, tumor is when limited to the maxillary sinus mucosa, and then it is T1. T2 is causing bone erosion or destruction, including extension into the hard palate or middle nasal meatus. And T3 is when it invades the bone of the posterior wall of the maxillary sinus, floor or medial wall of orbit, pterygoid fossa. T4 is divided into T4A and B, when T4A is when it involves the anterior orbital contents, skin of the cheek, pterygoid plates, infratemporal fossa, cribriform plates, sphenoid or frontal sinuses. And in T4B, the tumor invades any of the following: the orbital apex, the brain or middle cranial fossa, and any other lymph node perineural invasion apart from V2. And so in this case, the diagnosis comes out to be carcinoma of right maxillary sinus, clinically T4A, N1 and M0. The TNM staging is stage 4A. So the routes of spread for maxillary sinus carcinoma, anteriorly and laterally it can come out on the cheek or this or skin. Posteriorly, it can go up to the pterygopalatine fossa, infratemporal region. Medially, it can go to the nasal cavity, nasolacrimal duct can be involved, and superiorly to the orbit or the ethmoid sinus, and inferiorly to the palate or the buccal sulcus. There are two important lines and Ongren's line and Lederman classification, which comes in picture when we are talking of maxillary sinus tumor. The Ongren line is it is a line existing between the medial canthus of eye and angle of mandible, and it just divides the maxillary sinus into two: the suprastructure and the infrastructure. The suprastructures have the better prognosis, have the poorer prognosis, and the infrastructure have better prognosis. And the Lederman classification, as we see here, are the two horizontal lines which passes through the floor of the orbit and maxillary sinus, and it also makes the these three structures: suprastructure, mesostructure, and the infrastructure. The suprastructure includes the ethmoid, sphenoid, or the frontal sinus, and olfactory part of the nose. The meso is the maxillary and the respiratory part, and the infrastructure is the alveolar process. Maxillary sinus, usually the involvement of nerve and the perineural invasion, which is better seen in MRI. We need to know the maxillary nerve, which if we can appreciate over here, this is the maxillary sinus, and the middle superior alveolar branch, which combines with the infraorbital nerve, and along with that, it goes to the foramen rotundum. So this tract needs to be known, because if there is any perineural invasion in the patient, then the entire tract up to the skull base, where the foramen rotundum, the entire tract need to be treated. So in this case, the tumor is locally advanced. So what is the most appropriate therapeutic strategy? Whether the surgery and the post-operative RT, neoadjuvant chemotherapy with TPF followed by surgery and then radiation, neoadjuvant concurrent chemoradiation followed by surgery, or concurrent chemoradiotherapy, or any of the above. So I'll go to the next slide. And in maxillary sinus tumor, the important thing is the surgical resection, and it involves medial megalectomy and en-bloc ethmoidectomy. The approach is craniofacial, and it required if the tumor extends superiorly to the ethmoid roof or olfactory region. We need to know about the certain surgical resection technique which are used, and the medial megalectomy is used, which removes the medial and the inferior turbinate contents within the ethmoid and the maxillary sinus. It is indicated in patients in which the lesion involves the entire lateral nasal wall, not extending into the orbit or anterior cranial fossa or maxilla or alveolus. And then there are infrastructure and the suprastructure maxillectomy. In the infrastructure, there is the removal of alveolus, floor of the antrum, inferior part of the pterygoid plates. Here we can see the orbital floor is intact. However, because of this, the patient after infrastructure maxillectomy often require a prosthetic obturator because of the removal of the alveolus. And the infrastructure maxillectomy is indicated in a lesion involving the alveolus, hard palate, or any bony erosion. And the suprastructure is removal of orbital floor, upper part of the maxilla. And in this, the hard palate is intact. And any lesion which involves the orbital floor needs to go for a suprastructure maxillectomy. And along with that, the patient will require a reconstruction of the orbital floor. So the patient can also, the other two type is the subtotal maxillectomy, wherein the entire maxilla is removed, which is a combination of medial maxillectomy, removal of dentition, alveolar ridge, and the hard palate. And in the total is the removal of the subtotal along with the orbital floor. The role of primary ART with or without concurrent chemotherapy in maxillary sinus cancer patients are only in those who are not fit to undergo surgery or having any comorbid condition or poor performance status, and patient who declined radical surgery. And whenever there is an orbital encroachment of sinonasal cancer, it is the treatment becomes controversial, because the optimal treatment strategy for patients for orbital preservation, so neoadjuvant therapy has been tried to in patient if require an orbital exenteration for locally advanced sinonasal cancer. So my next question is, what is the incidence of nodal involvement in carcinoma of maxillary sinus? As we see commonly in oropharyngeal cancers, it is the level 2 lymph nodes are most commonly involved, and it is very common. However, most of the patient who comes with the carcinoma maxillary sinus, there is not much of lymph node involvement. The options are 5 to 10%, 10 to 20%, 20 to 30%, or all the above. So I'll just tell the answers. The 5 to 10% involvement of nodes are usually seen in adenoid cystic carcinoma, wherein the 10 to 20% undifferentiated carcinoma and 20 to 30% lymph nodal involvement is seen in case of adenocarcinoma and squamous cell carcinoma. So the answer would be all of the above. The patient received treatment which was 3 cycle of NACT using DCF, and patient underwent right composite resection of total maxillectomy along with the removal of the floor of the orbit, low ITF, inferior turbinate, and floor of the right side of the nose, right supraomohyoid neck dissection, and flap under GA. When the histopathological report came, it came out to be YPTXN0. So there was no viable residual carcinoma which was present. The margin were free, LVI negative, PI9 negative, and lymph node 0 out of 45. So looking at this, this histopathological report with no tumor, because the patient had undergone a DCF cycle, neoadjuvant chemotherapy cycles. There's some consideration, pre-radiotherapy consideration in patient is an intraoral stent is kept to open the mouth and depress the tongue out of the radiation field used in...
Neha, what was the histology in this case?
Squamous cell carcinoma, ma'am.
This is a pre-op, na? Post-op, there was no viable tissue present.
No viable.
Okay, continue.
After palectectomy, stent can be designed to hold a water-filled balloon to obliterate the large air cavity, and on orbital exenteration, defect can also be filled directly with a water-filled balloon to decrease dose delivered to the temporal bone. So we have to look into this important point for dose homogeneity. So the water-filled balloon can be kept. Conventional radiotherapy field portals are if it is involving the suprastructure or extending to the roof of the nasal cavity and ethmoid cell, then the 3 fields are used, the anterior and the right and left lateral fields, and the lateral fields are kept 5-degree tilt, and wedges can be used of 60-degree. For the anterior portal, the superior border is above the crista galli, and to encompass the ethmoid sinus, and in cases of absence of orbital invasion, it can be kept at the lower edge of the cornea. Inferior is 1 centimeter below the floor of the sinus. Medial is 1 to 2 centimeter midline to cover the contralateral ethmoid extension, and lateral is 1 centimeter beyond the apex of the sinus or falling of the skin. The lateral portals are the Superior are the floor of anterior cranial fossa. The anterior is behind the lateral bony canthus, and posterior covers the pterygoid plates, and inferior correspond to the anterior portal. And for the boost volume, they encompass the tumor bed while sparing the optic pathway. For infrastructure, the use with no extension to the orbit or ethmoid, the ipsilateral anterior and ipsilateral wedge pair are used of 45-degree, and lateral portal again have a 5-degree tilt to avoid the beam divergence into the contralateral eye. The RT plan for this patient was adjuvant concurrent chemoradiotherapy, because the patient had received a new adjuvant chemotherapy. So concurrent chemotherapy was added with weekly cisplatin, and the patient received to the high risk and the low risk 60 gray, and in 30 fraction 54 gray and 30 fraction of dose per fraction 200 and 180 respectively. The target volume, which was
Neha, before we go on to the IMRT, this thing, can we just discuss a couple of things? I don't know whether two things which offhand I can think of asking is that when you are talking about the placement of balloon, can somebody tell us exactly what do the balloons do? How do they enhance? Neha said that they increase the dose homogeneity, which is correct. But how does a placement of balloon or obturator or any, why water-filled balloon in the first place? What does water do? Or any other equivalent tissue? And why do you need to place that? So replace air is Salman what he's saying, but why do you need to replace, yes, tissue equivalent, but why do you need to replace the air over there? And the second question, I don't know whether you talked about, was the posterior tilt, the 5 to 10 degrees posterior tilt. How does that help us, the posterior tilt? For the lens, which lens? Same side? Of the opposite side. What happens to the lens? Contralateral eye, right? So it is the contralateral eye or lens, and because that gets affected, because of the divergence effect. As you go from ipsilateral side to contralateral side, the divergence would be more, and that is a very avoidable way of thinking. Second thing you talked about, so the contralateral lens is something that you are taking care of. That will depend. Divya has asked whether it is about the lens or the cornea. It will also depend upon what dose is being received. What is the dose limit for lens and what is the dose limit for cornea? Remember, cornea is not a live structure. It does not sort of revascularize or anything. So it has a dose limit of 30 to 40 gray, and you do not exceed that. Yes. So because once damaged beyond that, then you will not be able to do anything. And 5 gray to the lens, that is single dose. Salman, what about fractionated dose? What happens at 5 gray? What happens at 10 gray? What happens at 12 gray? You need to know that. What are stationary cataracts? What are progressive cataracts? Then only will you be able to identify, right? So then the other thing is also fractionated 25. No, that's not correct. The safe bet is, yes, 12 to 14 is something that you should not exceed for progressive cataract in fractionated radiotherapy. So we kind of stick to 10 gray because these are small structures, and that's our policy, that we stick to about 10 gray. Where do the maxillary sinuses fail? And so how do you cover that? How do you ensure better coverage? So these tend to fail if you look at the orbit, that is, and when you take the orbit is a pyramidal structure, it goes like posteriorly. As you go posteriorly, it becomes, it's like oblique, it goes superiorly. So you should be covering the anteriorly when you place the beam, your posterior extent of maxilla, which is superior to the anterior part of the maxilla, you should be covering that well, because that's where oftentimes we fail. Okay? Especially in conventional. I think Rashi, please take over the target.
There was very valid question why this patient was given concurrent adjuvant CTRT if there was a complete pathological response.
Because the patient was having a locally advanced disease and the patient had received a new adjuvant chemotherapy.
Receiving new adjuvant chemotherapy is not an indication for concurrent. Ashutosh, your view, we just want to know.
Hello.
Ashutosh.
Yes, Dr. Neha. So, why was chemo thought of in a maxillary sinus cancer?
Initial presentation was a locally advanced with one lymph node, T4A, but the patient had received the 3 cycle of neoadjuvant chemotherapy, and after which
So again, why new adjuvant chemotherapy was given in this case? See, this was probably what we sometimes get in a rare situation is a mixed variant tumor. So it's not the classic squamous cell cancer. It could be a elements of sinonasal cancer also in the maxilla. So in that, usually sometimes cisplatin etoposide is given as new adjuvant, and then you can think of, if you have done a craniofacial resection or a maximal a suboptimal resection, then you can. It is better to give concurrent chemoradiation. So this is especially when we have a mixed sinonasal cancer and or elements of, it's not a pure squamous cell or adenoid cystic type cancer.
Can Neha continue?
Hello?
Rashi, you want to say something? Neha, you can continue.
For post-op patient, if in the CTV HR, if this any positive margin or gross residual margin is present, then the dose or any extracapsular nodal spread, then dose up to 66 to 70 gray is used. For CTV primary, the primary tumor bed with 1 to 1.5 centimeter, and the intermediate dose surgical bed can receive 57 gray. And however, we use the HR dose for the primary CTV and the surgical bed, and CTB 3 or the low dose if there is any neural invasion or skull base margin, and along with the elective nodal volume if indicated. This is my last slide. Thank you so much.
Any question from participant? Suppose this patient was surgically inoperable due to any other reason, suppose patient moribund, and you have to plan this patient for the radical RT. So what will be your dose schedule and dose prescription in this patient?
For radical RT, for conventional fractionation, we have to go up to the 70 gray, and the entire tumor volume along with the gross node should receive 70 gray, or with the SIP technique, if you're using, we can also use 66 gray, and the low risk volume should receive at least 54 gray, the elective nodal radiation, and if there is any PNI positive patient in the MRI, and then we have to trace to the skull base foramen, and that should also receive the 54 gray.
My second question is, do you prescribe ophthalmic examination all these patients of maxillary antrum?
If
in the investigation part?
if the tumor goes, if in this patient, the tumor was invading into the orbital structures. That's why the ophthalmic examination was done in this patient.
Okay. Nita ma'am, you want to say something? Your comment?
Yes, one thing Neha has presented both the cases very well and not extensively dealt with. There will always be some queries that are remaining. I think people are asking. One odd question that has been repeatedly coming up in this particular case discussion was whether or not you would address the ipsilateral side. But what, like Dr. Ashutosh talked about, that we are dealing with something either squamous or something that is, a variant of sinonasal that we are dealing with. So I think it is better that we treat the ipsilateral neck. But having said that, I would say that this patient has behaved very peculiarly. This patient is a squamous cell carcinoma, extensive disease, gone into the orbit, and you give chemotherapy and it just melts away with PCR. That's something normally one would not expect to see. And that's why you're having these queries. So most of the times, squamous will not behave in this manner. There will be an element of residual disease, which we will have to tackle from our end. And so these questions would become, we would have to deal with it. So I would just say that, yes, it has behaved very like a chemosensitive tumor, much more than what I would have expected a T4A tumor to have behaved. But I would agree with what the way Neha has addressed this case. And yes, CTRT should be given, including the addressing of the ipsilateral neck. So, Sulbhi, Rashi, what are your comments?
Very well presented by Neha on both the cases. But I just want to tell one thing, Neha, because whenever a case is given to a resident in practical examination, patient does not carry the biopsy report. So we have to address all these in investigation prospectively. So we have to tell the differential diagnosis.
Ma'am, your voice is down.
Just a minute. Now it is clear?
Yeah.
Yeah, I just want to say that it was very well presented by Neha, definitely. But in the examination, residents are usually given just a case, clinical case. The patient is not having biopsy or the CT scan. So we have to present the case like this, that this is the clinical presentation of the patient, signs, symptoms. Then we have to present the complete examination, how to proceed further. Then we have to present the differential diagnosis also. Suppose in this case, what will be the differential diagnosis? I just want to ask from Neha or any other can give the answer. What is the differential diagnosis in case of the maxillary antrum? Anyone can answer. Sparganosis is basically an infection, okay, which is very well mimicked with the maxilla, maxilla. So you have presented very well.
So, ma'am, actually,
yeah.
One thing important in a paranasal sinus tumor is the entire volume marking and the line of management will depend on the histopathology.
Yeah.
So we have to closely look at the histopathology, whether it is squamous, is it a mixed variant, a small cell variant, an adenoid cystic, or a sinonasal type, or even a variant of lymphoma or a nasopharyngeal cancer coming down into the sinus. So because whether or not to go for chemotherapy, sandwiching with chemotherapy, surgery alone plus RT alone, or going up to the base of skull into the foramina for radiation to take care of perineural invasion. So that is important.
Definitely, you are right, Ashutosh here. Rashi, you want to say something? Any comment?
For differential diagnosis, I think benign tumors, infections can be the differential diagnosis in maxillary sinus tumor.
Yeah, sinusitis
sarcoma or sinusitis or
fungal infection may be there, definitely. So you have to exclude one by one in your examination. This is for the resident only. which I am telling you. Rashi, want to say something?
No, ma'am. Actually, you are very right. Dr. Neha, she has presented very well. But we have, you will be given the case from the basics. So all things should be covered. And how with the clinical examination, you can expect if the eye is involved, the structures that can be involved. If you take the history, you can understand what are the structures that have been involved. So that you have to actually understand. So in this class we cannot cover actually everything, so I think the Neha has done a good job.
Yeah,
That's all.
definitely she has done a very good job with this limited time. Thank you so much, Neha. Dr. Ashutosh, can you conclude?
Sure. Thank you, ma'am. I think that's it was a good presentation, and one case itself would have been big. Comment to it's a commendation for her that she was able to finish both.
Definitely. And she did an excellent job. So thank you so much, all the participants. Thank you, Neha. Thank you, Dr. Ashutosh. Thank you, Dr. Punita ma'am, for such a guidance and for such a remarks. Thank you, Dr. Rashi. Thank you, RPG Life Sciences. And thank you, all the participants. If any query, you can post me. Your answers will be given. Thank you so much.